I know that we have a bias towards our future self. We don't value pleasure or delayed gratification. We don't value it the same way as present gratification. The challenge then for the medical community in pretty much any kind of interaction, it seems, is that the dissemination of information is not enough.
Right.
We actually have to have them understand it. They have to be able to apply it, and they have to be able to remember to apply it. And then I guess lastly, they have to be motivated to do it.
Yes, right. So one of the most distinguished health educators in the United States is a man named Larry Green, who is emeritus professor at the University of California, San Francisco. And he and a colleague, Marshall Kreuter, came up with a model that they called the precede-proceed model of health communication. And this was probably about 30 years ago. And they said, we are all subjected to 3 layers of outside influences that motivate us or reinforce our behaviors and so forth. Predisposing variables. And predisposing might be the family unit in which you grew up. If both parents were smokers, you're much likely to be a smoker. But there are other predisposing variables that can be on the positive side. Enabling variables. If you're a smoker trying to quit and you have a supportive spouse who communicates her desire for you to quit in terms of her love for you and her desire to have you remain in good health, get old together and so forth, it's going to be much more powerful than some random health person telling you that, right? So that's the that's the enabling. And then the reinforcing. And the reinforcing are everything from your own response to the behavior change. Your food starts tasting better. Your girlfriend or your wife says, wow, it's so nice. I don't feel like licking an ashtray every time I kiss you anymore. Things like that, those are powerful reinforcing things. So what Green and Kreuter did in this precede-proceed model is they said, if you stop and figure out what it is you want to help your patient do in terms of behavior change, then probe in your history taking for the predisposing variables. When did you stop exercising? Tell me about that. Or what is it about your diet and the way you eat? How did you learn as a child what was regarded as good food? And then move on to the other enabling and reinforcing factors in the same way. Then you can craft an individual health promotion message that takes those. Now it takes time, you've got to be motivated, interest. And sadly, a lot of people who are at that primary care interface, family docs, general pediatricians, general internists, are finding that they're expected by whatever health system they work for to do everything in 15 minutes. And it begins to be a challenge because getting to know your patient takes time, and communicating those kinds of ideas about behavior change. The other interesting thing that I think is happening now more and more as we have learned more about human behavior and what motivates change is that this concept of internalizing things, that initially when you're asked to adopt a health-promoting behavior, many people will feel for the first month, 2 months, even a year of their trying to do that, that they are adopting something that doesn't feel natural or normal to them. That's sort of external. They're being urged by their doctor, they're being hounded by their family members, they're whatever. And then something happens, they internalize the notion that this is a good thing to be doing. And then they improve in terms of recidivism, in terms of being able to maintain that positive health behavior. And again, we're talking about time, patience, and multiple inputs of encouragement and so on. But I think I'm generally quite optimistic about the continued advances in cognitive science and social psychology and personal psychology about learning the kind of bootstrap things that clinicians can do with their patients. It shifts a little bit when you're trying to do things for large groups of people, because then you have to generalize about such important differential things as gender and ethnicity and class and age and so forth. I mean, those are huge variables. And when I chaired the Preventive Services Task Force back in the late 80s, we were asked by the Department of Health and Human Services to do essentially evidence-based review of all of the preventive interventions that could be carried out in the clinical setting, not public health interventions, but in the clinical setting. So we borrowed from our Canadian colleagues a typology about the quality of evidence. So things that had been learned in randomized prospective clinical trials were grade 1 evidence. Things that were learned in cohort studies, case control studies, well-conducted time series studies before and after the intervention and so on, were grade 2. And expert opinion was grade 3. When you had nothing else to go on, we say expert opinion is not enough, but people who have thought carefully about things, even in the absence of a randomized controlled trial, have something to offer. We went through over 60 different conditions and about 160 interventions. So for example, breast cancer, one condition but 3 interventions at that time. Mammography, clinical breast exam, and self-exam. And we reviewed peer-reviewed papers. I think the initial target, we collected about 5,000 peer-reviewed scientific papers pertaining to these 60 conditions. We had to throw out about half of them because the method section of the paper just wasn't clear enough or well enough written to be able to determine whether this was indeed a randomized clinical trial that was properly conducted, elimination of confounders and bias and all the rest of it. But the 2,500 that were left were in New England Journal of Medicine, JAMA, British Medical Journal, good, solid scientific reports. And then to our dismay, we found that of those 60 conditions, there were only about 7 or 8 that had grade 1 evidence supporting their use. So we then had a very unique kind of communication problem. And that was, what do you say to doctors and to their patients about what we called grade C, or recommendation C, which was there is neither sufficient data to suggest that this should be done, nor is there sufficient data to suggest that it shouldn't be done. And it was sort of these kind of coin toss decisions about some very important health factors. Well, the whole process then got a tremendous boost when a consortium of insurers in Northern California, Kaiser Permanente, Blue Cross Blue Shield, covering about 6 million lives, I believe. They said, we will start reimbursing clinicians who carry out the A recommendations of the U.S. Preventive Services Task Force. And that caught everybody's attention because one of the big barriers for prevention preventive medicine, it's just that doctors didn't feel they should get reimbursed. But it also put tremendous pressure on the research community to do something about filling in the data gaps. And a lot of very productive studies came out of that. Now I don't know how many recommendations. I'm not keeping close tabs on the Preventive Services Task Force these days, but it's probably tripled or maybe even quadrupled. So we're building a firmer scientific foundation, but the messaging and how to communicate that to the average clinician and to the average patient seems to have been most effectively motivated by financial reimbursement issues.